Good evening, doctor. So we have covered a lot of things in genetics. Mm, so we are now on multifactorial inheritance. So what we've covered is we've covered autosomal dominant disorders, we've covered autosomal recessive inheritance, we've covered the X-linked ones, and we've covered some topics on trinucleotide repeat disorders. We've covered chromosomal abnormalities, karyotypes, Turner syndromes, and mitochondrial inheritance, genetic imprinting disorders. And now we shall be doing multifactorial inheritance. So genetics is a very volatile topic and everybody feels that. I'm sure the students who were there in the last class, they remember whatever we discussed last time. Is that it? Yes? You remember most of the topics?
Yes, sir.
Great. So this time around, we will be finishing genetics, and these are very interesting topics, and they come repeatedly in the exam. So let's do multifactorial inheritance. Basically, multifactorial inheritance is caused by the interaction of genetic and environmental factors. And a very, very common example is skin color. So skin color is basically multifactorial. Not only it is genetically predetermined, it has polygenetic inheritance. So polygenic inheritance, not just one gene is responsible for skin color. Moreover, the exposure to environment can also change the skin color. Hence, the example of multifactorial inheritance. It is caused by interaction of genetic and environmental factors. Other pathological examples would be neural tube defects, diabetes mellitus. If somebody has a gene which can cause diabetes mellitus type 2, they can actually keep their weight lean, they can avoid uh, carbohydrate intake, keep exercising, and these people can actually have a well controlled diabetes even if they get it. Then hypertension is also multifactorial inheritance. Now, why do you need to remember this? Because these two topics have been asked in the exams time and again in true and false statements. That diabetes mellitus has a multifactorial inheritance, that is correct. So is correct for hypertension. Let us take an example of a case scenario that a couple has a child with spina bifida. Now, the mother is currently pregnant and is asking you about preventive measures. Can I prevent my second child from getting spina bifida? What is the chances of my second child also having spina bifida? So, what will you recommend? Increasing protein intake, prenatal vitamins with folic acid, early ultrasound to detect abnormalities, and avoidance of tetrogens. Any idea?
Prenatal vitamins.
So we would like to give this patient a good dose of folic acid. So folic acid replacement we will do. So neural tube defects is a multifactorial disorder and it can be prevented with folic acid supplementation before and during early pregnancy. A 50-year-old man with a strong family history of diabetes mellitus develops polyuria and fatigue. So he's 50 years and he has a strong family. Strong family history means either the parents have diabetes or the siblings have diabetes. What is the genetic basis of this condition? Now, this question has again, time and again appeared in the exam. So, autosomal dominant inheritance, polygenic inheritance, X-linked inheritance, or autosomal recessive inheritance. So, what is the answer to this question? The answer is polygenic inheritance. So, type 2 diabetes mellitus is a multifactorial disorder caused by multiple genes and also combined with environmental factors like obesity and lifestyle. So, this was about multifactorial genetics. Now coming to structural chromosomal abnormalities. Now chromosomes, they basically, each chromosome is taken from one parent So each limb of the chromosome. So this is how the chromosomes are formed. So let us say some part gets deleted or some part gets duplicated or some part gets translocated or some part gets inverted. For example, let us say ACC becomes CCA. So this has actually inverted its position completely. So this is an inversion. For example, Cry-Du-Chat syndrome, Dijord syndrome, and Robertsonian translocation. We read about Robertsonian translocation in Down's syndrome. Okay. So let us understand from questions how questions can come from structural chromosomal abnormalities. A newborn with a weak, high-pitched cry is noted to have a small head microcephaly, hypertelorism, and a ventricular septal defect. Genetic testing reveals a 5p deletion. What is the diagnosis? So 5p deletion. Now deletion is a structural chromosomal abnormality. You need to remember that. They can ask in this fashion also. Although the answer is known to everyone, it is Cry-Du-Chat syndrome. Yes, it's a Cry-Du-Chat syndrome. And it is caused by the deletion of short arm of chromosome number 5. And the children, they cry like a cat and they have intellectual disability because their frontal lobes are small sized and facial abnormalities. So they look like, this is how they look like. They look like this. So microcephaly with hypertelorism and facial abnormalities. This is how they usually look like. It is Cry-Du-Chat syndrome, 5p deletion. 5 is chromosome number 5. P is the short arm of chromosome. Long arm is known as Q, and it is deletion. A 3-month-old boy with hypocalcemia, tetany, and a congenital heart defect. Genetic testing shows microdeletion in chromosome 22, long arm, 11 segment, second base. What is the most likely diagnosis? Cry-Du-Chat, Turner, Dijord, or Beckwith-Widman? So this is classical Dijord syndrome. So in Dijord syndrome, there is thymic hypoplasia, hypocalcemia, cardiac defects, and T cell deficiency. This is a total cramming. I know it is a ratta. But then you need to remember that Dijord syndrome is not a mitochondrial inheritance. Dijord syndrome is not a multifactorial inheritance. Dijord syndrome is not an autosomal recessive or autosomal dominant or an X-linked disorder. Dijord syndrome is basically a problem with the long arm of chromosome number 22. And in that long arm, 11 segment, second base is deleted. So this is micro deletion. As far as Cry-Du-Chat is considered, it is basically a large deletion on the short arm of chromosome number 5. So that is Cry-Du-Chat. Dijord is 22q11.2 deletion. Is that clear? This is, although this is cramming, but you need to remember this. Okay? Very important. Robertsonian translocations, दो ही तो हैं usually which will be asked in the exam. Cry-Du-Chat and Dijord syndrome. Sir. Okay.
Sir.
Yes.
Also, one time Dijord syndrome.
Say again.
Dijord syndrome.
Yeah, you want to know about it?
Yeah, yes.
Okay. So basically, Dijord syndrome we study in pediatrics usually, but for us in genetics, it is important. What I should say, it is an important disorder because it is associated with a particular kind of genomic deletion in which there's a deletion of second base on the 11th segment of the long arm of chromosome 2. So Dijord syndrome, in effective, it's basically a pediatrics domain. It is associated with T cell deficiency. So it is basically an immunodeficiency disorder. So immunodeficiency disorder of T cells, and also there is a deficiency of development of third and fourth pharyngeal pouches. So what is the tissue which is derived from third and fourth pharyngeal pouches? Mediastinum, thymus. So there are problems with the thymus development. Then there are conotruncal abnormalities. Why? Because again, mediastinum, conotruncal. Conotruncal means the aorta and the pulmonary artery. Now these are problematic. All right. So truncus arteriosus, tetralogy of Fallot, interrupted aortic arch, ventricular septal defect, they all can occur in DiGeorge syndrome. Then thymic hypoplasia will lead to what kind of deficiency? Which cells will be deficient? In thymus hypoplasia, thymus is known for T cells. So there will be T cell deficiency in this condition. And if somebody is T cell deficient, they will be prone to which infections? Viral infections. They will be prone to which infections? Fungal infections. So, and also to tuberculosis, atypical infections. So these are the problems of T cell deficiency. Okay. Also develops from third and fourth pharyngeal pouch is a gland known as parathyroid gland. So parathyroid gland will be deficient. So if parathyroid gland is not formed, then what will we see? The patient will have hypocalcemia. And what will hypocalcemia do? Recurrent fractures. So pathological fractures, or what can happen? Tetany can happen. What can happen? Tetany and seizures can happen because of hypocalcemia. And mental retardation can happen because of hypocalcemia. So because of the deficiency of third and fourth pharyngeal pouch formation, there are deficiencies, or what I can say is non-formation of thymus, of conotrungus in the heart, of parathyroid gland, and of course multiple craniofacial abnormalities. Like I drew a face for you, dysmorphic feature. The ears will be large, the mouth will be small, there will be hypertelorism, and they can have cleft lip or cleft palate. Other problems are intellectual, of course. These, they will always have a mental issues with them. So how do you diagnose these patients? How do you diagnose? So diagnosis is based on number one, clinical features, so appearance. Number two, what will these patients have? Recurrent infections. They will have recurrent infections, and they will have congenital heart disease. They will have hypocalcemia. They will have hypocalcemia. And if you check their parathyroid levels, they will be primarily low parathyroid hormone levels. Okay. And you can get a specific T cell counts done. So T cell counts are known as CD4 CD8 ratio. They will be down. Okay. So this will be disturbed. So you will come to know that the patient has deficiency of the T cells. Otherwise, if you want to do a genetic diagnosis, what will you do? You will send a genetic sample. From where will you take the genetic sample? Any idea? Where do you take the genetic sample usually?
Bronchial mucosa.
Buccal mucosa.
Buccal mucosa, sir.
It is the buccal mucosa. Just like in COVID times, they were taking throat swabs. All you need to do is take a buccal swab. So you check them for what is the diagnosis test? It is FISH. What is FISH? FISH is fluorescence in situ hybridization. What will it tell you? What does the patient have? So it will tell you that there is a problem with the 22nd chromosome long arm. You want to go further inwards, you perform a test that we learned in the last lesson, microarray assay, microarray analysis. So what does it show? It shows that there is a deletion of 22q11 second segment. And of course, serum calcium levels and serum parathyroid levels have to be done. So in DiGeorge, you will not administer any live viral vaccines. This you will never give them. Okay? Live viral vaccines are not to be given. Big no. Okay? Anything else?
No, sir. Very well said, sir.
So,
Thank you.
So this is what is important from MCQ point of view, that one is the syndrome you need to identify from the facial feature, from CD4, CD8 cell counts, from hypocalcemia, congenital heart defect, echocardiogram, and along with that, you do not give them any live viral vaccines. This is important. So that is DiGeorge disease caused by microdeletion on 22nd long arm 11.2. Is that okay? And how do you investigate? Fish plus micro array assay. How do you treat? Give them vitamin D supplementation, give them calcium. Aajkal to we have a recombinant parathyroid hormone also available in the market. So you can give that to them, but that will only help them, not have seizures and tetany. Otherwise, whatever mental deficiency that they have, it cannot be recovered. All right. Now coming to a very important topic, which is a bridge between pharmacy and genetics, that is pharmacogenetics. So some people are fast acetylators, some people are slow acetylators, some people have a fast metabolism of certain drugs, some people have slow metabolism of certain drugs, some people have G6PD deficiency right from the birth, and you cannot give them Primaquine. So these are the problems that you need to know and understand when applying genetics to your patients in the hospital or in the outpatient department. So what is pharmacogenetics? It is the knowledge of how genetic variations influence drug metabolism and the response to them. For example, there are so many polymorphic forms of CY cytochrome P450. It is one of the most famous enzyme, cytochrome P450. It has polymorphism. So it is an excellent example for pharmacogenetics. Then coming G6PD deficiency and HLA-B5701 in a specific drug of HIV, that is Abacavir. It will lead to a hypersensitivity response. So we have actually identified. These are some examples, and usually MCQs will come from these only because they are more robust and more trained to the students. A 35-year-old man of Mediterranean descent is prescribed Primaquine for malaria prophylaxis. The moment the patient was given Primaquine, the patient develops hemolysis shortly after starting treatment. What is the most likely genetic cause? So what is the answer?
G6PD deficiency.
So G6PD deficiency. So they do not have this enzyme in their body. So how will you diagnose G6PD deficiency? Any idea? Any person who can give me a response on that? How do you work up a patient of G6PD deficiency? Somebody tells you, I think this patient has G6PD deficiency. What are you going to do? Any idea? So G6PD is an X-linked condition, predisposes to hemolysis when exposed to oxidative stressors like Primaquine. So when I say hemolysis, okay, tell me what are the diagnostic tests for identifying hemolysis? Anyone? Your
Direct
aspirants?
test.
Say again?
Direct home test.
Paraquine?
Direct home test, DCT.
Okay, direct Coombs test, direct, indirect, both. But before that, will you have
LDS,
something?
LDS level.
Even
LDS.
before that,
Peripheral it means
Yes, you get a peripheral blood smear to look for
hemolysis, adjoint.
Schistocytes.
schistocytes. Number two, if the hemolysis is happening, what will be produced? Serum bilirubin. Which fraction will be increased?
Indirect.
Direct. Direct.
Serum bilirubin will be increased. LDH will be increased. LDH is a byproduct of breakdown of plasma membrane. So wherever cellular damage occurs, LDH increases. Anything else? Anything else?
Haptoglobulin.
So, if RBCs are broken down, how will bone marrow compensate for a rapid breakdown of RBCs?
Increase reticulocyte count.
So, we will do a reticulocyte count, which will be increased. Bilirubin indirect will be elevated. I was just thinking about it. Indirect. Direct is after glucuronidation. So, indirect hyperbilirubinemia will be there. Indirect. Sorry for. So, okay, red count will be increased, and when the hemolysis happens, a protein is consumed. Which protein? Which binds to free hemoglobin, haptoglobin levels. What will happen to haptoglobin levels?
Reduce.
Yes, they will be reduced. So these are the generic tests for hemolysis. So number one, PBF. Number two, serum indirect bilirubin. Number three, reticulocyte count. Number four, increased LDH levels. Number five, decreased haptoglobin levels. And we can do a Coombs test also. Negative. This will be negative. Why negative? Because Coombs test is positive in
Autoimmune disease.
okay. So anything specific for G6PD hemolysis? They are known as Haynes bodies. Okay. And anything else that you can do with is G6PD enzyme level or enzyme assay you can do. All right. Is that clear? Is there any benefit of having G6PD disorder?
Plasma idiopathy therapy.
Yeah. So the pearl, MRCP pearl, is that these people are inherently resistant to Plasmodium falciparum. Is that okay? So G6PD is an X-linked condition, and we need to remember about this. It is a very important condition. Usually hematology forgets about it. It is only the genetics which remembers about it. All right. Okay. A 28-year-old HIV positive patient develops fever, rash, malaise after starting abacavir. Genetic testing will show HLA-B5701 allele. What is the most appropriate next step?
Discontinue abacavir.
Yes. So you have to discontinue abacavir, otherwise they can have anaphylaxis in the next dose. So this is important for us. For example, you can get a question that a patient of HIV positive was being given highly active antiretroviral therapy. After taking the first dose, the patient developed rashes. He did not come to hospital, got better on its own, took a cetirizine. Next day, he is brought unconscious to the hospital. All swollen, angioedema is there, lips are swollen and labored breathing. Serum tryptase levels were done, they are elevated. What is the next best step? So the next best step is to give injection.
Adrenaline.
Adrenaline.
So you give injection, yeah, adrenaline or epinephrine. Then what was the primary diagnosis? What was the primary diagnosis? What will be the diagnosis?
Anaphylaxis.
Anaphylaxis. But this is not complete diagnosis. Anaphylaxis to
Drug induced.
it is
Abacavir.
abacavir. So what will you look for? You will get a HLA-B 5701. Okay. So
Yes.
HLA testing is very routinely done for these patients. If you are getting a starting the patient on this condition, HIV patients. This is HLA-B 57. Does HLA-B 57 ring any bells? You are all students for MRCP exam. Have you read about something related to it? HLA-B 51. Anyone? This was about 57. I'm asking about 51. Anyone?
Becher disease. Becher disease.
Yes. Okay. So what is pharmacogenetics? Basically, it is the study of how an individual's genetic makeup influences their response to drugs. It aims to optimize the efficacy of drugs and minimize their adverse drug reaction. Anybody heard about clopidogrel resistance? This is another question that usually comes in the exams. So clopidogrel resistance is also genetic. If somebody is resistant to clopidogrel, the patient will have instant thrombosis and the patient will be needed to be shifted to ticagrelor. Are you understanding what I'm saying?
Yes.
And then there is another inherited condition which is azathioprine sensitivity. So if the patient who has a what is the there is an enzyme which is deficient, I think CTP. There is this enzyme which is deficient in certain population. Yeah.
TMPT.
TPMT.
TPM, yes.
Yes, TPMT deficiency. Good. So in those patients, this thiopurine metabolism will not occur. And if it does not occur, what will happen? What will happen? The azathioprine will not be metabolized. It will continue to show its effect, and the patients will end up with bone marrow depression, severe liver dysfunction, and the patient becomes very unwell after starting. So in certain countries, it is important that before starting the patient on azathioprine, you get TPMT levels. Okay. So this is another type of genetic variation that just came to my mind. Clopidogrel resistance and azathioprine sensitivity. So variations in genes can affect drug absorption, its distribution, its metabolism, and excretion, which is called ADME, influencing its effect and toxicity, there are two types of enzymes which are metabolizing the drugs in our body. One is the P450 system, which is phase 1 enzyme, which modified the drugs to make them more polar and polar, electrically polar to for excretion. Phase 2 enzymes make sure that the drugs are conjugated properly to enhance their water solubility. So pharmacokinetic and pharmacodynamic variants are also there. Those genes which affect the pharmacokinetics, they affect how the body processes the drug, and those which are pharmacodynamics variants, they affect how the drug interacts with its target. So let us go through some pharmacogenetic variants. Cytochrome P450, these people, if they are very aggressive phenotype, they will be known as ultra rapid metabolizers or extensive metabolizers, intermediate metabolizers, and then poor metabolizer. For example, codeine. Codeine is converted to morphine. People who are poor metabolizers may have reduced analgesia, and ultra rapid metabolizers, they risk the toxicity of morphine, because codeine will be converted eventually to morphine. People who have poor metabolism, they will have lesser morphine, and people who are ultra fast metabolizers, they will have high level of morphine. So these people can actually have morphine toxicity. So this is because of the cytochrome P450, which metabolizes antidepressants, opioids, and beta blockers. Then cytochrome P2C19, which metabolizes clopidogrel, and which, so the people who are poor metabolizers, they have reduced activation, increasing the risk of thrombosis. So this gives clopidogrel resistance. Again, cytochrome P3A, 4, and 5, they are involved in metabolizing more than 50% of drugs, including statins and immunosuppressants. So tacrolimus may fail if the patients have very high cytochrome P3A5 activity. If it is very high, the tacrolimus dose will be required in a higher dose. That is why the renal transplant surgeons, they always keep insisting on TAC levels. Why? If somebody does not have an active enzyme, then TAC levels will remain high and patients can have tacrolimus toxicity. But if the enzyme is very active, then unfortunately the patient may have a renal graft failure. Same way, TPMT, thiopurine methyltransferase, metabolizes thioprines like azathioprine and mercaptopurine. Deficiency of this enzyme will lead to overdose, leading to severe myelosuppression. Testing is recommended before therapy. Same way, N-acetyltransferase 2, which metabolizes drugs like isoniazid, hydralazine, and sulfonamides. So these people, if they are slow acetylators, they risk isoniazid toxicity, and those who are fast acetylators, in them treatment failure can occur. Treatment failure will lead to tuberculosis not being treated properly. Same way, SLCO1B1, it encodes a liver transport protein for statins, and these people in C allele, they have high risk of statin induced myopathy in these patients. Then HLA alleles, we remember HLA-B57 will give hypersensitivity to abacavir. HLA-B15 risks Steven-Johnson with carbamazepine. Carbamazepine is notoriously associated with Steven-Johnson syndrome, but it is the HLA-B association which leads to this. And HLA-A31 carries broader risk of carbamazepine-induced anaphylaxis also. Same way, G6PD, whose deficiency predisposes to hemolysis with oxidant drugs like primaquine and other sulfa drugs. VCOR C1 and cytochrome P2C9, they are involved in warfarin metabolism and sensitivity. So variants will lead to changes of doses and also the risk of bleeding. So applications are, of course, people who have, for example, stent thrombosis, people who have statin-induced rhabdomyolysis. So you need to know that if I have a patient of, or case scenario of such a patient, this is the enzyme which I need to investigate the patients for. Same way, there is an oncotype DX test in breast cancer, which evaluates genetic markers for chemotherapy response. So we don't, if there is a notorious term in people with breast cancers known as TNBC. What is TNBC? Anyone? It is a very famous term these days in exams. Anyone? So it is triple negative breast cancer. So it is basically when we check the patient for estrogen, HER2/neu, and another receptor, prostaglandin for
ERPR.
progesterone. Yeah, ERPR, progesterone. So estrogen, progesterone, and HER2/neu. So when these receptors are negative, it is called triple negative breast cancer. And in TNBC, apart from chemotherapy, patient needs to be given immunotherapy. And the most famous immunotherapy for CA breast is anyone? I think it is. It goes by the name pombilizumab, something like that. You can check it online. Pombilizumab, something like that. So it is also very in these days this question. So you need to be prepared for. Now coming to something which is very important for Mrcp is prenatal genetic testing. Prenatal genetic testing and screening, very important. So it involves non-invasive prenatal testing, which is known as NIPT. There are guidelines for it. Amniocentesis and chorionic villus sampling. Why it is important? We need to detect chromosomal abnormalities like trisomy 21, 18, and 13. What is trisomy 21?
Down syndrome.
It is very important that Down syndrome is properly diagnosed in time. How the questions will come? A 35-year-old pregnant woman undergoes NIPT. NIPT is non-invasive prenatal testing, which shows a high risk of trisomy 21. What is the next step in management? Repeat NIPT, ultrasound for knuckle translucency, amniocentesis or chorionic villus sampling, or terminate the pregnancy.
Amniocentesis.
So what we will do is amniocentesis we will do, because in amniocentesis, because NIPT, it is just a screening test. A diagnostic test will be needed to confirm the chromosomal abnormalities. So you need to understand the difference between screening test and diagnostic test. So NIPT, non-invasive prenatal testing, it is basically a screening test, and amniocentesis or chorionic villus sampling is a diagnostic test where you can authoritatively say that yes, this is, and then it is a family's decision. A pregnant patient is concerned about neural tube defects in her baby. Which kind of prenatal screening is most specific for this condition? Maternal serum fetoprotein, non-invasive prenatal testing, fetal echocardiography, or amniotic fluid bilirubin? Yes.
NIPT.
So basically the neural tube defects, so you need to get maternal serum alpha fetoprotein. So maternal serum alpha fetoprotein, any neural tube defect can occur. For example, anencephaly. For example, we just did a question on spina bifida. So spina bifida. So they can have encephalocele also. So whenever something of that sort happens, there is a test that you can do. So you can do a screening beforehand. So this is the question about prenatal screening. So in screening, you need to do sabse pehle maternal serum alpha fetoprotein. So this is a fetal protein that crosses the placenta into the maternal circulation. When do you do that? 15 to 20 weeks of gestation. Okay. Ideally 16th week. If it is If it is elevated to more than 2.5 times, then it is a indicator for open neural tube defects. So that means this is a basically a neural protein which is released into the maternal circulation. Low MSFP may indicate chromosomal abnormalities also. Okay, then what else you can do in screening? One is the MSAFP, maternal serum alpha fetoprotein. Then you can do ultrasonography. Is there any specific ultrasonography? Yes, it is called high resolution ultrasound. So this is also done during similar 18 weeks gestation. So you can get a spina bifida. There is a special sign which is seen in ultrasound of spina bifida. What is that known as?
Banana sign.
Very good. One is banana sign, and another is also eatable. That is lemon sign. Lemon sign is flattened frontal bones of the flattened frontal bones, and banana sign is herniation of cerebellum. Okay. Of course, in anencephaly, there will be absence of cranial vault that you can see on ultrasonography, and encephalocele, you can actually see visibly, you can see that. Then, of course, after this ultrasonography, you can do a this amniocentesis. Okay. In amniocentesis, what is important in amniocentesis for neural tube defects? One is amniotic fluid alpha fetoprotein will be elevated. So this was maternal serum alpha fetoprotein. This is amniotic fluid alpha fetoprotein. Anything else? Anybody remembering? Acetylcholine esterase will be increased in the amniotic fluid. Okay. So this becomes diagnostic of these conditions. And then diagnostic will be, again, there will be genetic testing. You can do karyotyping, vagara, but that doesn't help. This is all that we have for neural tube defects. And how can we prevent neural tube defect? Somebody answered very early.
Folic acid. And vitamin.
Okay. So the answer is maternal serum alpha fetoprotein. Elevated maternal serum alpha protein is associated with open neural defect. And so even if there was a amniotic fluid alpha fetoprotein, that would also be the correct answer. All right. So let us go through the prenatal genetic screening and testing guidelines in UK, particularly as recommended by NICE and NHS. So let's focus on early identification of potential genetic and developmental issues during pregnancy. You need to remember these by heart. So screening tests are there, and then diagnostic are there. Screening is first trimester combined screening between 11 to 14 weeks. So we do a blood test. We check for nuchal translucency ultrasound to look for Down syndrome, Edwards, and Patayus. Non-invasive prenatal testing, which is NIPT, it uses maternal blood to analyze cell-free fetal DNA for common chromosomal anomalies. So we may or may not find. So it is just a screening test. Blood tests for conditions like sickle cell anemia and thalassemia are recommended before 10 weeks of pregnancy. Then they do a 20-week anomaly scan, which is a detailed ultrasound to identify structural abnormalities like spina bifida or congenital heart issues. If you want, you can take a photograph of this page. This is all I have summarized in one page. Okay, then comes the diagnostic test. So in the diagnostic test, there are certain pregnancies which we are doing for high-risk pregnancies or where they had either previous gestation with confirmed anomalies. So amniocentesis is performed from 15 weeks on amniotic fluid sample. Chorionic villus sampling between 11 to 14 weeks. Usually everything should be done before 16 weeks so that if you can decide on miscarriage and all. Rhesus factor screening. NICE recommends non-invasive testing for fetal rhesus factor RHD genotype in rhesus negative women, avoiding unnecessary anti-D immunoglobulin if the fetus is also rhesus negative. Infectious diseases screening early in pregnancy. Tests are recommended for torch complex like HIV, hepatitis B, syphilis to gain timely interventions and protect the fetus. Always remember, in true and false, screening is voluntary. And women are counseled on the implication of test result, including their decision regarding further continuation or testing. It is very important. You cannot force anyone to abort. You just have to tell them that this is the problem that the child has. You might need to abort the pregnancy. But if they say, I want to continue, you cannot force them. Genetic testing and counseling, another important part. Nobody will cover this. I have specifically covered these portions because you will not find them in standard textbooks. So key points are that this genetic testing identifies inherited conditions, carrier status, and predispositions. So counseling is vital to interpret the results and assess recurrence risk. These are the questions which are usually found in the exam. A 30-year-old woman with family history of breast cancer is referred for genetic counseling. Testing reveals BRCA mutation. What is her lifetime risk of developing breast cancer? 15, 40, 60 to 80% or 90 to 95%. So BRCA1 mutation carries 60 to 80% lifetime risk for breast cancer and 40 to 60% for ovarian cancers. Okay. So there are two types of mutations that we usually see. These are basically breast cancer genes. That is why they are known as BR and CA. So it is known as BRCA genes. So they are the genes, they are known as BRCA genes are basically tumor suppressor genes. Okay. So they are involved in DNA damage repair. So imagine if these deficiencies or mutations are there, they will lead to breast cancer. Okay. So what kind of cancers patients have? Breast and ovarian cancers. All right. So BRCA1 mutation, it breast cancer lifetime risk is 60 to 80% and high chance of TNBC, that is triple negative breast cancer. BRCA2, it is basically 50 to 70%, almost same, and it also includes male breast cancer. And other cancers that these people can have is ovarian cancer, pancreatic cancer, and in males, prostate cancer. Okay, so these are the mutations, other cancers that come along with that. A couple has a child with cystic fibrosis. Both parents have no symptoms. What is the probability that their next child will also have cystic fibrosis?
25%.
How so? How so? So cystic fibrosis is a
Autosomal recessive disease.
yes, so it is a enzyme-based process. So last time I told you that metabolic processes are usually autosomal recessive. Structural diseases are autosomal dominant. So it is a CFTR protein deficiency because the enzyme is located, the gene is located on chromosome number 7, and it is a delta F508 mutation that occurs, which leads to this. So it is an autosomal recessive. So let us draw XY. Oh, sorry. इसमें तो XY का कोई फर्क ही नहीं पड़ा. So let us draw that this patient has cystic fibrosis. Let us say we mention it small c. So this is a male who has a small c, capital C. Female also has small c, capital C. So CC. Because it is autosomal recessive, we understand that both the parents have to be carriers. Okay? Both the parents have to be carriers. So what is the chance that the next child will also have cystic fibrosis? It is
25%.
25%, 1/4. Why? Because it is autosomal recessive. Only if both parents are carriers, then they can lead to this. So genetic testing and counseling in UK as per the guidelines. So key principles are, we need to identify inherited conditions like cystic fibrosis, like Huntington's disease, predict the susceptibility to specific conditions like BRCA1, 2 for cancer risk, confirming a clinical diagnosis, for example, Duchenne's, for example, Marfan's, and guide them while making reproductive choices. So types of genetic testing. So one is diagnostic testing, which confirms or rules out specific genetic condition. For example, we do a BRCA1/2. Predictive testing offered to asymptomatic individuals with family history of genetic condition, for example, Huntington's disease. Carrier testing, for example, thalassemia, cystic fibrosis, hemophilia. Prenatal testing, we've already done that. Chorionic villus sampling and all, and non-invasive prenatal testing. So genetic counseling is very important. You can read about that. Genetic counseling is typically provided by a trained genetic counselors or clinical geneticists. We as doctors don't do that, but there are guidelines that you need to do. So as a nice guidelines, they recommend offering combined screening for trisomy 21, 18, and 13 to all pregnant women. NIPT is offered to women identified as high risk for initial screenings. Cancer testing is BRCA1/2 is recommended for individuals with strong family history of breast or ovarian cancer. Nice guidelines for cancer outline criteria for testing and preventive measures like risk reducing surgery. So they already have guidelines in place.
Sir, what did you say about trisomy? Can you please say it again? The last page.
Yeah, for trisomy 13, 18, 21, you need to screen all the pregnant women. All. Is that okay?
Yes, sir. Okay. Thank you.
So we need to screen
Yes, sir.
all
Thank you.
the pregnant women. So for trisomies. Okay. Rare diseases, whole genome sequencing is also available in England, and undiagnosed diseases, rare diseases under 1 lakh genome project initiative, they are doing it. For example, what do you call them? I just had a patient who was investigated for that. That is, I'm not getting it. There's a disease in which they are, so yeah, spinocerebellar ataxia. Spinocerebellar ataxia, they are working up these patients. Such a high level genome sequencing is being done because of whichever diseases do not have treatment now and have a genetic basis of them, they are extensively sequencing their genomes so that they can be prevented. So you need to know these things, although only 3 or 4 questions will come, but definitely they will come. So you need to be prepared for them. Now we will just go through some important conditions which are genetics related. For example, Marfan syndrome, single gene disorders. So Marfan syndrome results from fibrillin 1 gene mutation. For example, cystic fibrosis, CFTR. So people are tall, stature, aortic root dilatation, and lens dislocation. A 16-year-old boy with Marfan syndrome presents with chest pain and shortness of breath. A chest X-ray shows mediastinal widening. What is the most likely diagnosis? What has happened is mediastinal
Aortic dissection.
Yes, so aortic dissection has happened. Marfan syndrome predisposes to aortic root dilatation, and when it crosses, what is the cutoff sign? 5 centimeter. Whenever the aortic root is dilated to more than 5 centimeter, it becomes aneurysmal, and there are chances that it might dissect or even rupture. A woman with Marfan syndrome is pregnant. What is the most significant complication during pregnancy? Preterm gestational diabetes, aortic rupture, or preeclampsia?
Aortic rupture.
So aortic rupture can happen even while straining. So pregnancy increases the risk of aortic dissection or rupture in women with Marfan syndrome due to hemodynamic changes and weakened connective tissue. So this was about single gene disorder. Cystic fibrosis is also single gene disorder. So oncogenetics. What is oncogenetics? We just read about it. Cancer and its genes, oncogenes or tumor suppressor genes or DNA repair genes. So BRCA1-2 in breast ovarian, APC in familial adenomatous polyposis. So let us do some questions. A 35-year-old man, a young man, these are usually young. A 35-year-old young man has more than 100 adenomatous polyps on colonoscopy. Genetic testing reveals mutation in the APC gene. What is the most appropriate management?
Annual colonoscopy.
So what is the plan? What are you going to tell to the patient for annual colonoscopy? Anything else? So patient needs a removal of the colon. So this patient who has more than 100 polyps, you need to remove whole of the colon. Okay, colectomy will be needed. So take it as a homework that how do you classify that what step you are going to do in if the patient has a polyps in the colon.
Okay.
Okay. So when do you investigate? So what kind of disease? We've done that in the last class, that it is a structural disease. It is an autosomal dominant condition. And these patients, they have a 100% risk of progression to colorectal cancer. 100%. So what is the fun of testing them individually if we are not going to treat them beforehand? So people who have more than 10 to 20 polyps on routine colonoscopy, they are the ones where you start thinking and you get a genetic testing done. If they have a positive APC mutation, immediately start surveillance and consider prophylactic surgery. So it is very, very important that people who are young, who are in their 20s or in their 30s, that you remove their colon if they have such a high number of polyps along with APC mutation present. Remember, if APC is mutated, this patient today or tomorrow is going to get a colon cancer. Is that clear? And if you have ever had a colonoscopy showing that he had polyps and one of those polyps had a positive APC mutation, then you should immediately do a whole total colectomy. Remove the damn colon. Connect the ileum with the anus. So ileoanal anastomosis is done. Okay? Yes?
Yes.
So what will you mark as an answer? Yes. Colectomy. No colonoscopy. Colectomy. Colonoscopy to ho gaya. He had 100 adenomatous polyps on colonoscopy. And then you did a biopsy. It is APC positive. No fun of keeping the colon and polyps inside. Remove it. A woman with BRCA1 mutation undergoes risk reduction bilateral mastectomy. What additional screening is essential? पहले तो मुझे ये बताओ, what is the percentage of these lifetime risk कितना है for breast cancer?
60 to 80%.
Wonderful, wonderful. So these people, if they are going for risk reduction bilateral mastectomy, what additional screening is important? Yes.
For ovarian cancer, pelvic ultrasound.
Pelvic ultrasound. Okay. And serum 125 for ovarian cancer surveillance. All right. Now coming to mosaicism. What is a mosaicism? Mosaicism is two kind of people living in one person. So mosaicism occurs when two or more genetically distinct cell lines are present in one individual. So they can be somatic or germline mosaicism. For example, let us consider a condition where a 5-year-old boy who has cafe au lait spots, axillary fracking, and Lish nodules on ophthalmologic examination, but the genetic testing for neurofibromatosis type 1 is negative. What is the most likely explanation? Patient has all the signs of tuberous sclerosis. Okay? Yes? Or neurofibromatosis, sorry. So, but the gene is negative. What is the most likely explanation for this?
Moses gene.
Yes. What does it mean in the layman terms? In the layman terms, it means that the cells that I took for investigation did not have the NF1 gene. But that doesn't mean that there are no cells present which do not have it. So what is the NF1 gene present is on which chromosome?
17.
So it is chromosome number 17. So that means on chromosome number 17, this gene had to be present. Why? How do you diagnose neurofibromatosis? You only need two things. One is cafe au lait spots and other axillary freckling or neurofibromas or Lish nodules. Any two may be present. Any two. So yahan to three are present. So this is for all practical purposes. This is cafe au lait spots, Lish nodules. This is practically neurofibromatosis type 1. Okay. But you have to remember that these can have mosaicism, somatic mosaicism. So somatic mosaicism in NF1 can lead to localized manifestation. Even a negative germline testing, clinical diagnosis is based on feature. This is what I am saying, that the patient is no doubt neurofibromatosis. Why? Because he is fulfilling the criteria for diagnosis. The neurofibromatosis 1 gene, if you are lucky to find, it is okay. But if you are not lucky enough, then doesn't mean that the patient does not have neurofibromatosis type 1. Is that okay?
Yes, sir.
Yes? Good. A couple has 2 children with osteogenesis imperfecta. 2 children. Neither parent has symptoms. And testing for parental blood is also negative for mutation. What is happening here? भाई जेनेटिक डिसऑर्डर है, दोनों बच्चों को है, पर पेरेंट्स को कुछ भी नहीं है. And when you test the parents' blood, you again do not find any mutation. What happened? Where did the mutation go?
Germline.
This is a germline mosaicism. So this is a germline mosaicism, explains recurrent autosomal dominant conditions like osteogenesis imperfecta in the siblings when parents do not exhibit any mutation. Is that okay about genetic mosaicism?
Yes.
So it is like Harlequin. What is a Harlequin? This is Harlequin. 50% is colored and 50% is not colored. So this is how mosaicism appears. Some symptoms are there, but there is no correlation between genetic testing and the actual presentation. Same way, now let us go for epigenetics and gene expression. Very important. Epigenetics includes DNA methylation, histone. What is epigenetics? So we were starting from chromosomes, went into genes, and now we are going into the paraphernalia, which is supporting the genes. For example, the enzymes involved in the process. For example, the histone proteins involved in keeping the DNA segments together. So DNA methylation, histone modification, RNA interference. So epigenetics basically is related to the manifestation of a DNA segment. A child with Beckwith-Wiedemann syndrome is found to have increased risk of Wilms tumor. Which gene's abnormal methylation is responsible? TP53, H119 or IGF2 gene, APC, FMR1. So what is the answer? The answer is basically IGF2. So IGF2 is the gene involved in the abnormal methylation leading to embryonal tumors like Wilms tumor. The point is not that you remember this, although most of you will remember that P53 is associated with multiple cancers, APC is with colon, FMR gene is something else. So the insulin-like growth factor enzyme is usually involved in Wilms tumor. So, but it is associated with dysregulation of the methylation. Same way, a newborn presents with poor feeding and respiratory distress. Patient has severe hypotonia, and genetic testing confirms deletion of paternal chromosome 15q1113. What condition the child has? Anyone who was in the
Genomic
last class?
imprinting.
Very
Genomic
good. Genomic imprinting. So what is the diagnosis?
Prader-Willi.
Prader-Willi. So what is the best
Papa.
mechanism that explains this? Genomic imprinting. Prader-Willi. And if it was the maternal chromosome, then
Angelman.
Angelman syndrome. Very good. Now coming to psychiatric disorders. So this is basically, it is called psychogenetics. So nowadays, few questions have come, like a 22-year-old man with schizophrenia has a family history. Those who have prepared through the question banks, now they would know that these questions, they keep on occurring in the exam. A 22-year-old man with schizophrenia has a family history of psychiatric disorders in first degree relatives. What is the approximate heritability of schizophrenia? 10, 25, 50 to 80 or 100%? So bipolar disorder, schizophrenia, autism, they're actually polygenic. Sometimes there is a 50 to 80, even 100% similarity may be there. But to be on the safer side, it has 50 to 80% of penetrance into the families. Multiple genes are involved, environmental factors are involved, and there is a high heritability of schizophrenia. It is 50 to 80%. Same percentage like we studied in BRCA1 gene mutation and breast cancer. Same way, a 4-year-old boy is diagnosed with autistic disorder. His mother asks the chances of recurrence in the future child. What is the risk? 5 to 10, 15 to 20, 50 or 75? The answer is 15 to 20. That the risk of having an autosomal disorder, autistic disorder is 15 to 20%, reflecting the polygenic nature of the disorder. That means if you change the environment, there are chances that the child may come out of it. Trinucleotide repeat disorder, we have already done that. It might be just a revision for you here. It is caused by the expansion of trinucleotide repeats. So which diseases? CAG, Huntington's, CGG, Fragile X, myotonic dystrophy, CTG. We've already done questions. A 40. Anybody remembering Fragile X syndrome features? Macroorchidism is one of the criteria. In Huntington's chorea, it is the anticipation, although anticipation can be seen in all of the trinucleotide repeat disorders. What is the repeat threshold? Tell me, what is the repeat threshold?
More than 36.
Yeah, but what is repeat threshold? Define repeat threshold.
More than 3.
So, repeat threshold is basically when the disease manifestation comes when a set number of repeats are there. So, for example, if somebody has a higher number of repeats in subsequent generation, they will have a worse disease and it will present earlier in age. Okay? So, this is very important to remember that why anticipation is so common in trinucleotide repeat disorders, because it is based on number of repetitions. If the repetitions are more, the chances of having severe disease are more, and chances of having early onset of disease is also more. A 40-year-old man presenting with progressive chorea, presenting with psychiatric disturbance and cognitive decline. His father experienced similar symptoms at 50. What is the likely genetic mechanism?
Trinucleotide.
Very good. And what is the diagnosis?
Huntington's.
And what is the trinucleotide repeat?
CAG.
C8.
Wonderful. So this phenomena of early presentation is known as anticipation. A 6-year-old boy with intellectual disability, large ears, macroorchidism is diagnosed with Fragile X syndrome. What is the genetic abnormality?
CGG, trinucleotide.
Okay, good. So what is the gene? FMR gene, FMR1 gene leading to gene silencing. Okay. Mitochondrial inheritance. Also, we have covered in the last class. Let us do some questions. A 20-year-old man presents with painless bilateral vision loss. His mother and maternal uncle also have the similar symptoms. What is the most likely diagnosis?
The Leber hereditary optic.
Yes. And Leber's hereditary optic neuropathy. Can anyone tell me why these diseases are more manifested in neuromuscular system? Because of the more concentration of mitochondria in these organs. These organs are high energy consumption organs. So they have more number of mitochondria. If somebody is diseased, they will have more number of diseased mitochondria in those organs like muscles and nervous system. So eye is a nervous system. So the answer is Leber hereditary optic neuropathy. We covered it in the last class. It causes optic nerve atrophy and vision loss inherited from mother maternal inheritance. A 15-year-old girl presenting with weakness of muscles, seizures, and lactic acidosis, brain imaging shows stroke-like lesions. Her maternal relatives have similar symptoms. What is the diagnosis?
Melas.
Wonderful. It is Melas. Again, it is a mitochondrial inheritance. Now coming to sex-linked disorders. A 4-year-old, this is basically revision now. A 4-year-old boy presenting with difficulty walking, cough, pseudo-hypertrophy, positive Gover sign. What is the diagnosis?
Duchenne muscular dystrophy.
Why not Becker?
Difficulty in walking.
Because it was occurred in older children.
Yes, because of the age. It is just 4 years. And in 4 years, only Duchenne manifests so fast. So Duchenne muscle dystrophy is an X-linked disorder caused by mutation in DMD gene, leading to severe muscle degeneration. 7-year-old boy with hemophilia A requires surgery. What preoperative treatment is essential? Hemophilia A.
Factor 8.
So we will like to replace the factor 8. What is Christmas disease?
Factor 9.
Factor 9.
Now, copy number variation. So CNVs include duplications or deletions of DNA segments which are required. For example, DiGeorge. For example, Williams syndrome. So let us see. A 4-year-old boy presents with speech delay, hypercalcemia. So in DiGeorge, patients will have hypo. Why hypo?
वो parathyroid deletion.
Very good. Why parathyroid is not formed?
Brachial about third
and fourth parts of the brachial.
Very good. And which other organ is not formed?
Thymus.
Thymus. So what will they have again and again?
Immunosuppressant रहेंगे sir.
Infections. What kind of infections?
Viral infection, tuberculosis.
Viral infection, fungal infection, tuberculosis. So what will you not do which you will do in other children?
Don't give live
vaccines.
Live vaccines. We will not give them live vaccines, and we will treat them for parathyroid deficiency by giving either recombinant parathyroid hormone or vitamin D and calcium. Okay, so that is 22q11. Okay, so 4-year-old boy presenting with speech delay, hypercalcemia, and a friendly personality. Genetic testing shows 7th long arm, 11th, 23 subunit deletion. What is the diagnosis?
Williams.
Why it is not Down syndrome as an answer?
Trisomy 21.
Yeah, because trisomy. Yes. Why is it not Turner syndrome?
45X है sir.
Yes. Why it is not Angelman syndrome?
Genomic imprinting.
Yeah, but genomic imprinting is fine. Which gene is involved there?
15.
So it is 15th chromosome, long arm, 15q. Okay. Yes. So, and of course, that is a maternal. So even by ruling out the options, you can reach the answer. So MRCP guys are very wise. When you go for tough questions like these, they will give you negative answers also. So A, B, and D are ruled out. So a good student who has read everything will be, even if they don't know Williams syndrome, they will be able to reach the diagnosis. So this is Williams syndrome caused by deletion of this. They have elfin faces, they have intellectual disability, but they're very friendly. A 3-year-old child with history of recurrent infection and cardiac anomalies is found to have a microdeletion in 2211-2. What additional feature is most likely?
Hypocalcemia.
Hypocalcemia. Wonderful. So, you guys are very well prepared now. You can go and just win the exam. Lysosomal storage disorders. For example, Gaucher disease, Fabry's disease, Tay-Sachs disease. Now, these are also mutations. Why? Because there's deficiencies of enzyme. Enzyme is a protein. Protein is formed by translation. Translation is the third step after transcription. Transcription is the second step after DNA replication. So definitely this is a genetic disorder. Gaucher's, Fabry's, Tay-Sachs. A 2-year-old Jewish Ashkenazi Jewish child presents with progressive neurodegeneration, cherry red macula, and no hepatosplenomegaly. What is the diagnosis? Niemann-Pick disease, Gaucher, Tay-Sachs, or Fabry's?
Niemann-Pick.
So basically Tay-Sachs disease because of hexosamine deficiency causing GM2 ganglioside accumulation. Cherry red macula is a characteristic finding. Okay.
Yes, sir.
A 10-year-old boy with Fabry's disease presents with proteinuria and peripheral neuropathy. What treatment can you give to this child? इसका तो treatment available है आजकल.
Enzyme replacement.
Yeah, so you can actually do enzyme replacement by alpha galactosidase A deficiency. Anybody knows an enzyme which is glucosidase inhibitor? Anybody? It is used in the treatment of diabetes. Glucosidase inhibitor. Acarbose. Voglibose. Okay. So whenever similar terms come, you should have a immediate recollection of such things. Okay, autosomal recessive disorders में single gene disease is sickle cell disease. Results from mutation of HBB gene with the substitution of glutamine to valine substitution. Key factors: vasoglucose crisis, anemia, and infections. So 12-year-old boy with sickle cell disease presenting with sudden onset left arm pain and swelling. What is the most likely cause?
Vaso-occlusive crisis.
Vaso-occlusive
Very
crisis.
good. Okay, there is an option B. What is osteomyelitis? Anything in particular with osteomyelitis in sickle cell disease? Anybody?
Bone infarct. Bone infarct.
But anything in particular? Osteomyelitis is infection. Which bacteria causes osteomyelitis more
Staph aureus.
often? It is Salmonella typhi.
Salmonella typhi.
Salmonella typhi.
So Salmonella typhi. Just ऐसे ही याद आ गया तो I discussed. A 6-month-old infant with sickle cell disease is started on prophylactic penicillin. Why?
Worm. Prevent sepsis and sepsis malaria. Sir, typhoid prevention.
No, because of these patients undergo
Malaria.
autosplenectomy.
Oh,
So you try to treat them for encapsulated organisms.
okay.
So their spleen automatically gets dead. Okay. So sickle cell patients are at an increased risk of encapsulated organism infection, making prophylaxis essential. But what is the reason? The reason is autosplenectomy. So because of recurrent splenic infarcts, this is what happens. Okay. Ultra important high yield genetic topics are genetic basis of Down syndrome. A 3-year-old boy is brought for evaluation due to developmental delay, hypotonia, single transverse palmar crease, trisomy 21 is confirmed on karyotyping. What is the most common mechanism underlying this condition?
Robertsonian transfer.
Robertsonian.
Okay. So it is basically meiotic non-disjunction. Robertsonian translocation is where you don't find a trisomy. Are you getting it?
Yes.
So, meiotic non-disjunction, one chromosome traveled together. So there came 3 chromosomes, 21. So this is what happened. What is translocation is that the third component exchanged itself and got connected here. So it is basically disomy only, but then the genetic material is into 3. So that is called Robertsonian translocation. Exchange. Okay. Okay. Cystic fibrosis diagnosis. A 6-month-old boy presents with failure to thrive, recurrent lung infections, steatorrhea, sweat chloride test confirms diagnosis. Which is the gene most likely important here? What is the mutation?
TFTR.
TFTR delta 508. Cool. Huntington's disease. 30-year-old man, progressive involuntary movement, irritability, memory loss. Father had similar symptom in his 50s. What is the genetic mechanism underlying?
Trinucleotide
Nucleotide expansion.
Good. I will take you back to Down syndrome, okay? Because some students were having doubt about mosaic this. Robertsonian translocation and all. 16-year-old girl is evaluated for primary amenorrhea. She has a webbed neck, widely spaced nipples, and short stature.
45X.
Turner syndrome.
Turner syndrome. Fragile X. 5-year-old boy, intellectual disability, macroorchidism, large ear, long face. Genetic testing reveals more than 200 CGG repeats in FMR1 gene. What is the mode of inheritance?
Recessive, sir. Autosomal recessive. No, sir. X-linked recessive.
So basically, it is a X-linked dominant. Whenever the X chromosome recessive with I mean, it is a boy, no?
Yes, yes.
So X-linked dominant. There is an X and there is a Y only in boys. Fragile X and X-linked dominant caused by this, leading to silencing of FMR1 gene. Mitochondrial inheritance. 22-year-old man, progressive vision loss. What is LHON? Several maternal relatives, same. What is the inheritance pattern?
Mitochondrial.
Okay. Prader-Willi, 6-year-old boy presenting with obesity, short stature, hypotonia, intellectual disability, genetic prepaternal chromosome 15q1113 deletion. What is the mechanism?
Genomic imprinting.
Very good. Marfan's, a 28-year-old man with history of aortic root dilatation, presenting with sudden onset chest pain, long finger, high arch palate. What is the gene mutation?
FBN1.
Fibrillin, FBN1.
So FBN1, Marfan syndrome, defective fibrillin 1, aortic aneurysms. Okay. HNPCC, Lynch syndrome, 45-year-old man diagnosed with colorectal cancer. Family history reveals multiple relatives with colon and endometrial CA. What is the gene responsible?
APC.
APC.
Are you sure? Lynch syndrome.
53, P53.
So it is MLH1 gene. It is Lynch syndrome is caused by mismatch repair genes like MLH1 and MSH2. It increases the risk of colorectal and endometrial. Somebody said 53. What is that disease known as?
This is breast cancer.
So there will be all sort of cancers in Lee-Fraumeni syndrome. That is P53, tumor suppressor. Yes. Okay. Last but not the least, sickle cell disease. 10-year-old boy, sickle cell disease, acute pain, fever, hypoxia, chest X-ray reveals bilateral infiltrates. What is the diagnosis?
Acute chest syndrome.
Acute chest syndrome. Thank you very much. Okay, we can search it here, right? Nice.
Hello, sir. Hello.
Yes, yes,
Yes.
yes.
Sir, how can I differentiate between Niemann-Pick disease and Tay-Sachs? Because both can have cherry red spot.
So Niemann-Pick and Tay-Sachs, how can you differentiate? How clinically?
Yes. Clinically or in MCQ actually. What should I look for?
So we will come to that. Let's first differentiate this, what do you say, the Robertsonian translocation.
Sure, sir.
Just give me, I was mentally there only. So, Robertsonian translocation. So what you see is, there's this very nice question that we did last time, that a newborn child with hypotonia, upslanting palpebral feature, matlab everything about Down syndrome. What is the recurrence risk for future pregnancies? It depends on parental karyotype. Why? Because of presence of Robertsonian translocation. So it is important to understand, where did the, yeah. So Robertsonian translocation. So this is how it happens. So in this translocation, what happens is that the total genetic material remains the same, and what you see is a trisomy. So for example, in this trisomy, you get an extra copy of this specific chromosome. So 1, 2, and 3. So this genetic material had to be differentiated and then developed into just 2, but then it got divided and could not relieve each other when it was moving away, the full formed chromosomes. When during DNA multiplication, when they were moving away, they just could not move away and they traveled together. But what is this Robertsonian translocation? So Robertsonian translocation is when the genetic material translocates and becomes an extra copy. So that happens when there is no loss or gain of genetic material. So that is Robertsonian translocation, balanced translocation. So what happens is this portion goes from this chromosome to the other chromosome, and this portion travels to the other chromosome. So there is no loss or gain, but at the end of the day, there are 3 chromosomes traveled. And that is why sometimes in Robertsonian translocation, the patients do not have the same symptoms. They will have milder symptoms. They will be having milder phenotype. Many times we see that if Down syndrome, if all of them are caused by trisomy 21, why they are different in behavior? Sometimes we see some is an extreme Down syndrome and some is a very mild Down syndrome. That is because there is no actual gain or loss of genetic material. So third chromosome traveled but did not carry any genetic material with it. So that is called this Robertsonian translocation. Acha, somebody asked a question. What was that?
Sir, how
Was
can we differentiate between Niemann-Pick and Tay-Sachs? Because both have cherry red spot and all.
Yeah. So we will just go through it. So there is a Niemann-Pick disease and there is a Tay-Sachs disease. Okay. So basically, both of them will have. So if you need to remember, Niemann-Pick disease also will have a cherry red spot, and they also have a cherry red macula. So you need to remember that usually Tay-Sachs will be infants, young children in Niemann-Pick disease. Young children. So this is very important, that Tay-Sachs usually present as very young children. So and it is not in Niemann-Pick disease that all of the children, they will have a cherry red spot. Few of them have. If I'm not correctly remembering, but if you can check it in the book, there are types of Niemann-Pick disease, and only one or the other has cherry red spot. Whereas in Tay-Sachs disease, cherry red spot is present in all the patients, and there will be no hepatosplenomegaly in Tay-Sachs disease. So this is how you can remember it clinically, that in Niemann-Pick disease, liver and spleen are also present. Liver, spleen plus eye. So red macula and this. Whereas in Tay-Sachs, only red macula will be there. Liver and spleen will be normal. So if the patient has hepatosplenomegaly, hepatosplenomegaly is a defining criteria for Niemann-Pick disease.
Okay.
So
thank you, sir.
You have to remember this, that hepatosplenomegaly is a defining criteria in Niemann-Pick disease, whereas it will be definingly absent in Tay-Sachs disease. You asked now, what is the differentiating one
Yes,
feature?
sir. Got it.
I also did not remember it at first instance, but once you revise it in your mind, no, Niemann's Pick disease is defined by presence of hepatosplenomegaly. So they will have a big tummy and spleen, their liver, and of course, in just one variant, I think they will have a red cherry spot. You please check it for me.
Sure, sir.
Yeah, but in Tay-Sachs disease, classically, if there is a hepatosplenomegaly, it is not Tay-Sachs disease. This is the dictum that if the child has, and moreover, Tay-Sachs presents very early with a lot of neurological manifestations and all. Where was this question? Tay-Sachs disease यहीं कहीं था क्या? अभी था ना? It was in some, yeah.
Lysosomal storage disorder.
Lysosomal storage में था. Yes. Yeah, यहाँ था. ठीक है? You see, specifically has been mentioned that the child does not have hepatosplenomegaly.
Yes.
So if, let us say, okay, if I have to change it into your question, so a 2-year-old Ashkenazi Jewish child presents with, we can change Ashkenazi Jewish or whatever, with progressive neurodegeneration, a cherry red macula and hepatosplenomegaly. The answer has changed. The answer now becomes?
Niemann-Pick.
Now it becomes Niemann-Pick disease. But if just this no has changed the diagnosis, just the presence of no has changed the diagnosis. So no hepatosplenomegaly, specifically mentioned because they want you to answer it, Tay-Sachs disease. Okay?
Yes, sir.
Answered. Good. Anything else? Okay then. So read genetics very clearly, very carefully. It is a very, very good topic and it can amalgamate into all the other topics that you read. It is such an important topic. Most of the people leave it, and because they don't know how to read it, so that is why this thing happens. Somebody has any question? No? In the chat, there is, what is the survival chance of patients with structural chromosomal abnormalities? See, survival chances in structural chromosomal abnormalities, we see that almost all of them, they live, but then it is the problem of, survival is a very, very difficult kind of a question. Survival chance is like chromosomal abnormality, structural. There are so many. Even Down syndrome is a structural chromosomal abnormality. We've added a chromosome. So they all live, they survive. So maybe, you have a question in mind which probably did not get the right words, but then they do survive. Everybody survives. It is only, something which goes wrong, and until the medical science has a treatment for that. Okay, guys. Have a good night. Have a good weekend. Bye-bye.